Good morning. My name is Mark Parascandola. I'm the director of the Research and Training Branch here at the NCI Center for Global Health. Thank you for joining us today for our Global Cancer Research and Control seminar series. This seminar series features talks by researchers and cancer control experts working in global oncology and provides opportunities for discussion and collaboration on impactful and innovative work addressing cancer morbidity and mortality worldwide. So today, I'm delighted to welcome Dr. Carla Berg to the Center for Global Health. Dr. Berg is professor in the Department of Prevention and Community Health at George Washington University's Milken Institute of School of Public Health, and she also serves as Associate Center Director for Population Sciences and Policy at the GW Cancer Center. Today, Dr. Berg will discuss her research in Armenia and Georgia, testing the effects of local coalitions to promote smoke-free air policies and compliance across 14 communities, and the adaptation and implementation of an evidence-based smoke-free homes intervention disseminated through local coalitions and national quit lines. She'll also address how these studies have integrated research capacity building through grants and related training programs. So Dr. Berg has extensive experience conducting research on tobacco and cannabis use in domestic and global settings. Her research has focused particularly on policy adoption, implementation, and evaluation, marketing influences, and the development and testing of scalable interventions to reduce NCD risk and related burdens. So before handing the session over to our esteemed speaker, I'd like to review a few logistics. First of all, please save your questions for the designated Q&A time immediately following the presentation. You can type your question into the chat box or use the raised hand feature under reactions on the Zoom panel. Second, please note that today's presentation is being recorded and will be available on our website at cancer.gov/globalhealth. And finally, you can find information about future presentations on our website and also on X at NCI Global Health. So now we can move on to begin the presentation. And so I'd like to welcome Dr. Carla Berg and turn it over to you.
Thank you so much for the kind introduction and for the invitation to be here today. I appreciate seeing so many people joining us, so that's really exciting for me. Well, I'll start. As Mark already mentioned, I'm going to talk a little bit about some of our research that we've been doing in Armenia and Georgia over the past decade, in fact. So this is really an exciting time to be able to give you an update on where we're at with some of these projects and kind of the wonderful things that have happened in these two countries through our partnerships. A little bit of background from my perspective. So I am from a itty bitty tiny town in South Dakota, 399 people at last count. And I was one of 8 kids, and my parents were each one of 8, and their parents were each one of, 10 or 17 kids. So, I mean, I'm pretty much related to the entire state of South Dakota. It is a true honor to be able to work in some of the capacities that I've been able to work, coming from kind of a modest beginning. And so to be able to travel and work with these partners in Armenia and Georgia and other places, and to be able to have an impact has just been such an honor and a pleasure. So I really want to thank NIH, NCI, Fogarty for all of the support to do some of the work that we've been able to do. This is just a smattering of some of the projects that we have had funded in the last few years. Many of them have been global in nature. And so the two in the middle, Gather and Gather 2, and the two on the far right, Zrunva and Access, are some of our projects there in Armenia and Georgia. So this was a paper that we had written in 2018 that was really emphasizing the importance of global research. And some of the key points that we made were that, doing global research really allows us to do some important things for research. So being able to leverage strategic settings and populations, which is crucial when you're trying to examine certain phenomenon or new issues or issues that need to be isolated or that are particularly prevalent in certain groups. Another great aspect of global research is being able to advance theory. when you're isolating a study to a single space, or you're not able to look at variations in policy or differences in how policy is implemented, you really can't talk very sophisticatedly about the impact of those different levels in terms of your theoretical or conceptual frameworks. And of course, it's really important to be able to do these things so that we can inform policy and practice. And finally, as we've been able to really consider this in the last few years since the COVID-19 pandemic, it is just crucial to build that global research capacity as we all rely on one another for public health. So our first project, Gather, I'll take us a step back. I had a Fulbright scholarship in Georgia in 2013 and was able to establish some really strong connections with the NCDC there in Georgia, and some of the universities, including Tbilisi State Medical University, and then also in Armenia through their NIH and the American University of Armenia. And through those connections, really got a huge understanding of the particular disparities that happen to plague those two countries, both in terms of tobacco use, but also secondhand smoke exposure. As you can see, currently, and this is even after some pretty strong regulations have gone into place, we still have nearly 50% or more of the men reporting, past month tobacco use prevalence, and far fewer women. That rate has really increased in Georgia in the last few years. And so the secondhand smoke exposure rates are just astronomical. And not only that, but the percentage of smoke-free homes is really quite shy. But these are, huge advances since some of our earlier work. One of the things that hasn't been done quite as often in low and middle income countries is the use of coalitions to advance public health. In the States and in many other places, using local coalitions has been a really important public health action. And for a lot of reasons, Georgia and Armenia are two countries where this is not part of their public health practices historically, in part because of the political climate there. And we had to be very careful about talking about coalitions when we initially started the work over there, because it was kind of deemed as a not particularly welcomed approach. So this is a grant that was funded by Fogarty in 2017 with my MPI, Michelle Kegler at Emory. And Michelle is one of the leaders in understanding how coalitions work and the processes that make them successful. And so this is one of the theories that she and Dr. Butterfoss published called the Community Coalition Action Theory. And the idea is that there are all of these different factors that are important in making these coalitions impactful, creating collaborative synergy, and ultimately being able to change health outcomes on a community level. So this was one of the conceptual kind of foundations of what we were doing during our first grant there from 2017 to 2023. So our aims were, first, to conduct a matched pair community randomized controlled trial to examine the impact of local coalitions to promote the adoption of smoke-free policies. And this really capitalizes on that opportunity to work in strategic settings and populations, in particular because this is not something that was part of their public health practice. And so being able to actually do a community randomized controlled trial was really unique. You could not do that in the States because there are so many cities and counties and communities that have some kind of coalition activity already happening. And this was a great opportunity to advance the theory that we were using as our foundation, because historically, these theories have only been established based on evaluations and not through experimental design. So this was a huge opportunity to advance that theory. And of course, this was important in being able to contribute to the evidence base to inform public health practice. And it's really gratifying to think about where we ended this study and how there were really substantial changes in public health practice at the end. And then ultimately to build research capacity. And this was important not only with our academic partners, but also our community level partners who are out doing the practice. So I gave you the timeline of 2017 to 2023. And if you can imagine what we were trying to do, this was a time that was really riddled with a lot of problems. So we launched the study in 2018. And so we had done a community member survey in the 28 communities in the 2 countries that we were working with. And then in 2019, we had just begun to start implementing the coalition processes and activities within the communities. Well, at the very outset of the study in 2018, Georgia actually implemented a national smoke-free policy. And so there was one thing that we had to consider is, what do we do in that context? Well, one thing that we knew was going to be a problem regardless was actual compliance or adherence with that policy. And we documented that early on as being a particular challenge. And that's been documented in other countries where they've implemented a national smoke-free policy, just getting compliance rates up, especially when these policies are implemented at the national level. So through 2019, we got the ball rolling and the coalitions were up and running. We had done training that involved coalition building and situational assessment, action planning and implementation. And then come 2020, the world went crazy and we had to deal with all kinds of things that were so unexpected, including, of course, the pandemic. And so, with all of the business closures and so, people going into isolation, that really impacted what we were doing because most of what we were doing was at the community level. And we were, working to implement smoke-free policies within hospitality and a lot of places that, no longer had a lot of traction. Not only that, but our partners were people working within the public health centers at the national level and at the local level. And clearly they had to kind of reconsider how they were going to approach this issue of tobacco use within the context of trying to deal with the pandemic. Turns out that they came up with some really interesting and effective ways to kind of tie the two together. It was actually really strategic and really worked out well in terms of being able to tie the tobacco use issue with COVID-19. Not only that, but also in 2020, there was the war with Azerbaijan for Armenia. And so that really disrupted things. And then as all of this was happening, the things that were happening in the Ukraine with a lot of folks transitioning to Georgia, Armenia. So then we finally get to 2021 and, the world had begun to settle a little bit and the coalitions were, beginning to get back into their communities. And then at the end of our grant period, when the coalitions were wrapping up their activity, we had already seen this movement in Armenia towards implementing a national smoke-free policy. So this is all to say that this was a time period where for our coalitions to make an impact in the communities and be remembered, we knew was going to be a challenge. So at the end of in 2022, we culminated the study. We completed surveys with the community members in each of the 28 communities. And along the way, we were working with the coalition members, doing key informant interviews with the leaders. We were doing surveys with the coalition members, et cetera. And so we were able to do an evaluation from the documents that we got from the coalitions. And then we were able to evaluate the effects of the coalitions within the communities through the surveys of the community members. So these are the 28 communities that we worked in. This was really exciting to be able to identify, the 14 communities in each country and then select 7. And they were matched based on region, distance from this capital city, and on resources allocated to their local public health centers. So we did a relatively decent job of doing matching across the 2 countries. As I mentioned, we had multiple trainings and annual meetings with all of the coalitions. This is just a smattering of some of the people who were represented within the coalitions and within our study team. And the projects that they implemented within the local communities were just fantastic. And they were so proud to share the great work that they were doing within public health center settings, within clinical settings. They loved working with the kids and with schools. So they had a lot of really great activities that they were able to implement. So as I mentioned, we were able to evaluate the coalition processes through the mixed methods interviews with coalition leaders and members, through member surveys, and through their action plan and progress reports. And so here's a few of the things that we found. Just great representation within our coalitions from education, public health, healthcare, government, media, and so forth. So that was an exciting finding, was that we had a lot of engagement and a lot of people who stuck with the coalitions throughout the kind of tumultuous period. Over 50% of our coalitions created at least one smoke-free policy, whether it was in factories or parks or etc. And this held true both in Armenia and Georgia. In Georgia, they were able to implement some of these policies in places like parks where it had not already applied. And here are some of the settings. And I used the Armenian and Georgian versions. They made a wonderful video summarizing the results of the study. And I didn't think that we would be able to pull that off necessarily so well in a webinar context. So I pulled some of their slides. But this just shows some of the places where they were implementing policies or actions. So that included in the educational spaces at schools, within public transportation, within hospitality, within the medical clinics, within some stadiums, ballparks, playgrounds. So they really did cover the gamut of a broad range of settings that they focused some of their coalition activities on. All of them promoted existing policy compliance via signage. The majority also promoted awareness events and educated public about COVID-19 and the tobacco-related dangers that were associated both with tobacco or with COVID and just tobacco in and of itself. And we were able to document that the coalition processes really did predict membership engagement and collaborative synergy, which was predictive of perceived community impact, member skills acquisition, and interest in sustaining their coalitions. And so this was something that we really had hoped would pan out because we had stood up these wonderful coalitions. They had been so active. And so we really wanted to, encourage them to continue on after the grant funding went away. And in terms of results at the community level, so these were the results based on surveys of 50 to 100 participants within these communities from 2018 to 2022. And so we were disappointed but not surprised that some of our outcomes did not turn out. We did not see an increase in people's receptivity to tobacco control policies, and we did not see any increases or any decreases in secondhand smoke exposure. However, we found that in the intervention communities, there were greater rates of smoke-free home adoption and a coalition awareness. So this shows that our coalitions were making their presence known in these communities. People acknowledged that there were these activities happening in their communities. And one great part about identifying this effect on smoke-free homes is that that's a very volitional activity. For somebody to implement a smoke-free home implies intentionality. Secondhand smoke exposure rates could have fluctuated for all kinds of reasons, including the fact that people were not in some of the public settings where policies had been implemented. And so that's one thing. And then we also know that there's reactants to smoke-free policies when they're initially implemented. So we thought it was a fantastic finding, very promising that we were able to identify this impact on smoke-free home implementation. So in summary, from our first study, we found that coalitions can be formed in varied socio-political contexts, and they can facilitate locally driven multi-sectoral collaborations that promote health, despite major contextual challenges, national legislation, global pandemic, war. So this was just a theme that cut across everything that we documented in terms of outcomes. And it really showed too, we were able to, convene all of the coalitions in the two countries, just the level of enthusiasm that the coalition leaders and members had for what they had been able to accomplish. And this is one of the slides that was in the video that they developed, and this was gratifying. This is a new approach for Armenia and Georgia and can be applied to address various public health challenges. And like I said, it was huge also that there was that commitment to sustainability, which really facilitated the next grant that I will tell you about. So this next opportunity arose from a couple of different projects culminating at the same time or being intersected to address this opportunity. So first of all, this grant builds on or capitalizes on the community-based infrastructure that the original Gather program had been able to develop. It also was able to capitalize on an evidence-based intervention to increase smoke-free home adoption. And so this was a project that was funded by a UO1 grant by the National Cancer Institute, I think in 2011 to 2016. And this was led by Michelle Kegler at Emory. And so this was a huge project that involved three plus large RCTs. The first one was an efficacy trial of a smoke-free home intervention in Atlanta, and then an effectiveness trial in North Carolina, and then in a replication trial in Texas. And then it was disseminated through a national grants program after the evidence had been generated. It now has been translated into Spanish, but not yet tested. It's in the process of being adapted for tribal communities in the US. And it also has been implemented through federally qualified healthcare centers using kind of a 5A's approach to identify people that might benefit from a smoke-free homes intervention. So those results are pending, but this is just the level of activity that this project has been able to generate, and just a lot of evidence along the way in the efficacy trial, effectiveness trial, replication trial, and dissemination trial, showing that not only is it able to increase smoking bans in homes, it also decreases exposure to secondhand smoke in the home and the number of cigarettes smoked among smokers. And the program is cost effective and has potential health savings from the program that outweigh the program costs. It's featured in a couple of different places by NCI and WHO as an evidence-based intervention, one of the very few that focuses on smoke-free homes and specifically within individual homes rather than multi-unit housing. As I mentioned, there's an adaptation that's just recently been developed for tribal communities. So it's in the process of being tested there. And it's also been adapted for a population in Barcelona. So our aims in this study are first to adapt the smoke-free home intervention to be culturally appropriate for Armenia and Georgia and develop in-country capacity for intervention, dissemination, and delivery. And because we have stood up these wonderful local coalitions, they will be instrumental in the dissemination process. And because our partners are the National Institutes of Health in Armenia and the National Center for Disease Control in Georgia, we can leverage the national quit lines as the delivery channel. And just to give you a sense of what this intervention looks like, the prior slides gave you a little bit of that sense, but there's 4 components to it. So immediately after participants are enrolled, they receive this toolkit. And the toolkit has all kinds of different activities in there. The core to it is a 5-step guide to a smoke-free home. And the theme is some things are better outside. And so you can see kind of these humorous, comical kind of images reflecting that theme. And the idea is that maybe the humor can help reduce any reactance among people in the home who might smoke. So it's, like I said, it's been shown to be effective now in several trials, and people really use the intervention packet and they like the theme. So we did focus groups in Georgia and Armenia already to get a sense for how we would need to adapt these intervention materials. And so we did things like change the imagery, massage some of the language, so some surface structure stuff that was, inherently needed. And then we've done a ton of research to identify kind of these deeper structure level things that we need to address in terms of like, what are some of the unique challenges that, face populations in Armenia and Georgia? What are some of the ways that we would want to encourage people to address those challenges? What are the things that are motives for, individuals in the US that might not be motivations for a smoke-free home in Georgia and Armenia? So we've been doing a lot of qualitative and quantitative research to identify those things and have adapted the materials accordingly. The second component is a coaching call, which comes 2 weeks after they receive that initial mailing. And so in the US, through the different ways that the intervention has been delivered, it originally was through the 211 systems and through coaches that were, part of the study team, but then was passed on to the United Way 211 systems, and then to the various different organizations that have implemented the program since then. And in Armenia and Georgia, like I said, we have this amazing opportunity to hopefully make a sustainable delivery channel through the national quit lines. 2 weeks after the coaching call, they get these additional materials. And the idea is that everything is kind of based on stages of change and social cognitive theory. And so some of this is a role modeling. So we have a photonovella that demonstrates or illustrates a story where a mother takes a child to the doctor's office. They talk about his breathing, implications on his respiratory system of secondhand smoke exposure in the home. She goes home and talks to their elderly grandmother about her smoking in the home. So it's a success story. It's role modeling about how you might have some difficult conversations around smoke-free homes and challenges implementing them. It also has a challenges and solutions booklet. So this is a great opportunity for the individuals who've been enrolled in the program who have been unable to implement a smoke-free home. How can you potentially troubleshoot some of the things that are common themes and common challenges? And so it gives not only the challenges, but a couple of different solutions to some of those prominent challenges. And then we had also found that a lot of folks wanted information about electronic cigarettes, as this was kind of an emergent theme in the early 2011, 2012, 2013 period, where people didn't know very much about those products, and some people still have a lot of questions about them. So this has been a really relevant piece of information to share. So for the Armenian and Georgian versions, the story stayed the same largely in the photonovella. But to be culturally relevant, I mentioned earlier the statistics regarding smoking prevalence among men and women. The story was changed so that they would have this conversation with a grandfather rather than a grandmother. And they wanted to include things like heated tobacco products, which are equally prevalent as e-cigarettes in Armenia and Georgia. So we included that in our information about electronic cigarettes. And as I mentioned earlier, we revised some of the challenges to address, things like social dynamics, types of housing, things like that. And then in the final mailing, so this is now 4 weeks after the coaching call, or 6 weeks after they are enrolled, they get this final mailing, which includes a newsletter, third-hand smoke fact sheet, and then some stickers and window clings to kind of reinforce the notion that this is a smoke-free home. And so the Smoke-Free Home newsletter has success stories and benefits that have come out of implementing a smoke-free home. This information on the third-hand smoke people find interesting. We provided some examples of that information to folks in Armenia and in Georgia, and we got mixed reviews in terms of whether this was important for them, but most found it novel and weren't aware of the topic itself. So we chose to include it. And of course, again, we changed some of the stories, some of the outcomes, of course, the imagery and the language. And in our focus groups, we identified some things that they wanted to change in terms of the imagery to reduce the focus on cigarette butts and things like that. Pets also are not as prominent in Armenia and Georgia, and the original intervention really featured this dog and the kid. And so we reduced the emphasis on the dog and had more emphasis on like sports and not, playing sports in the home. So that's just an overview of what that intervention looks like and some of the adaptations we've made already. So we're excited to launch. We're now like literally within 2 weeks of fully launching the intervention. And so this is going to be an RCT at the individual level of the adapted intervention on smoke-free home adoption among households in Armenia and Georgia. And so, as I mentioned, the coalitions in 7 of the communities in each country are going to be working within their communities to identify people who are potentially eligible and interested in the program. And they will provide those the contact information for those potentially eligible and interested participants or individuals to the national agencies. They will call and screen them for eligibility and enroll them in the study, and then they'll be randomized to intervention or control. And the national agencies will send out the mailings and deliver the coaching call through the national quit lines. And we are enrolling about 1,000 participants per country. We increased the sample size after consultation within our team and then working with our program officers. We were concerned that there might be some variability in terms of the ways that we adapted the intervention materials for the 2 countries, and that might have some impact on our outcomes. So we are increasing our sample size so that we hopefully can identify if there are any individual or differences based on country and adaptation. And then finally, we'll assess intervention reach, adoption, implementation, and maintenance potential, as well as related contextual influences, to kind of make sure that we're understanding what are the ways in which this might be a sustainable model for not only these 2 countries, but potentially inform intervention, adaptation, and sustainability in other countries or contexts. And this is just a timeline indicating where we're at in the process, and kind of hopefully we'll with the timeline for culminating the research. And so I mentioned that these projects also had the potential to, increase what we were able to do in terms of making a sustainable impact on the research capacity of these 2 countries. And so we were fortunate enough to get a D43 working with our colleagues in Georgia in 2019. And so we have been working with them. At this point, we have, I'll go through the aims, they're pretty parallel. In Georgia, the focus is on environmental health and NCD prevention and control. And so the first aim is to develop institutional infrastructure to support ongoing research training in Georgia. And we're working with 2 universities, Tbilisi State Medical University and the University of Georgia, to provide mentored NCD and EH related research opportunities, in particular emphasizing air quality and pollution, given that we had a pretty robust area of research, not only with our project, but with other projects in Georgia. And then to emphasize research dissemination and translation to inform policy and practice. As folks on the call might know, people have a tremendous opportunity to bridge research and practice in these countries. Many of them, begin in research and move into policy or practice, or vice versa, or are very, very closely connected to their policymakers and practitioners. So that's a huge opportunity to really emphasize research dissemination and translation. Similarly, we have a D43 that was more recently funded in 2023 that is in Armenia, working with our colleagues at the American University of Armenia. And this focuses on NCD prevention and control, with a particular focus on social determinants of NCDs. And so we're, again, working to enhance their institutional infrastructure and curriculum. We're providing mentored opportunities for research and catalyzing NCD-related research dissemination and knowledge translation to inform policy and practice. So, so far, we have trained 4 MPH students in Georgia and nearly 18 doctoral students in Georgia. And in Armenia, we took our first cohort of 4 master's students last year, and are accepting and taking on a second cohort of 7 master's students this year. It's a very exciting time because both of the programs really are showing huge potential, and the research is moving really quickly. So it's fun to see the students making such great progress and be in positions within their national agencies that really can make an impact. And I'm just going to continue for a brief moment talking a little bit more about some of the other things that we've been able to do because of the importance of global research and what it can teach us. So we had this other study in Israel that really helped us take what was happening in another country and be able to provide some insights on things happening here at home that I think were really relevant and important for us to know. So this was a R01 funded through NCI and the FDA related to the tobacco regulatory research initiatives. And so Israel was one of the first countries that had IQOS, a heated tobacco product, introduced there. So that was in 2016. It was originally introduced, I think, in Italy and Korea and a few other places, Japan, in 2014 and 2015. But Israel was definitely among the first that had its appear in its market. And so for the first while, it was sold as a regular consumer product, not regulated as a tobacco product at all, and then was regulated as a tobacco product, but under really weak regulations. And then in 2018, tobacco control legislation was passed that really increased how progressive that legislation was. And then in March of 2019, they implemented an advertising ban that pretty much covered everything, including point of sale displays. The only thing that it excluded was print media. And then other things went into effect in 2020, including the 65% text warning coverage on plain packaging. Now, why is this relevant to the US? Well, in the US, IQOS was originally introduced in 2019. And first it was just as a regular tobacco product, but then it sought out and was authorized to use the modified exposure authorization that FDA has as part of its MRTP authorizations. And so what we were concerned about and thought we would be able to learn from Israel is how IQOS has been promoting itself as a health product or a harm reduction product prior to the more progressive legislation, and assumed that that might shine some light on what they would potentially be using in their product marketing here in the US, particularly after they got the modified exposure authorization. And then, of course, in 2020, IQOS left the US due to a patent infringement lawsuit, but is back now. So this is a huge opportunity for us to continue that work because some really interesting things came out of that. Our first aim for that study was to identify IQOS marketing strategies in Israel and the US since its market entry via market surveillance and point of sale audits, and then examine consumer reactions to IQOS and its marketing among segments of the Israeli and US adult population. This was one of my favorite papers, only because the title was so good. It's like if a vape pen and a cigarette had a baby. That was people's best understanding of what this thing was. But clearly, people became more aware of it in the US prior to its departure. And of course, there's the opportunity that it will become more prevalent in the US in the coming years. So some of the things that we were able to anticipate because of our collaborations with Israel was that the imagery was definitely featuring women, racial and ethnic minorities, that there were all kinds of different themes that appeared in the marketing. So, for example, pre-MRTPA, they featured technology and things like that, which was similar to how it had been appearing in the Israeli media and marketing. But post-MRTPA, it showed up in a lot of different places, including places that focused on youth. So there were things like Team Cosmo that had ads for IQOS, when that clearly should not have been the case. And of course, post-MRTPA, they were also using a lot more of the health information or the harm reduction claims that were kind of embedded in the FDA authorized language. And I say kind of because their language was reduced exposure. But almost every person that we talked to in our qualitative interviews immediately translated that to reduced harm or safer, despite the fact that that's not what it said. In Israel, we were able to document a targeting of youth as well, by being placed near schools and through being placed by youth-oriented merchandise at stores. So a lot of things that we were able to identify that were common themes across the two countries, and I think really made the findings a bit more robust. This wasn't a strategy that we were just documenting here in the US, but that it is definitely being documented elsewhere. Another thing that we were able to identify was that these the FDA authorization was being used to was being exploited in other countries. Ads in other countries were basically suggesting that the US FDA had authorized this language because it was, a testament to its harm reduction, which violates really the language that was authorized for them to use. And we wanted to understand the extent to which those FDA endorsements made any difference when being presented to people both in the US, because we assumed even if it's being used in another country, it's online, people are seeing it, whether they're here or there. So we tested this with both our participants in the US and with our participants in the FDA. And there were some effects based on the FDA endorsement. And once again, people did not understand the reduced exposure versus reduced harm language. And in some cases, actually thought that the reduced exposure language was the stronger language because it talked about the broad range of effects. And so they thought that that was the stronger message rather than the may potentially reduce harm. Another thing that we found by looking at some of the ads was that there was this really interesting opportunity that presented itself. So one of the ad messages said, looking for an alternative to cigarettes. And then it provided information. IQOS significantly reduces the production of harmful and potentially harmful chemicals. And then this kind of synergy with the Surgeon General's report or warning, quitting smoking now greatly reduces serious risks to your health. And I thought, isn't that an interesting pairing? And so we looked at this in experiments, and then we looked at it with qualitative interviews. And that combination of the warning and the advertising message had a pronounced impact on people's perceptions in not a good way. And in fact, in our qualitative interviews, individuals actually believed that this was a promotion from the Surgeon General of IQOS for quitting smoking. And that was truly frightening. I'll just mention one future plug as well, as we're having all of these states in the United States legalize commercial cannabis. We can think about, what's happening in other countries as well, especially as these things are happening across an increasing number of countries. And I think it would be really interesting for us to be able to glean the benefit of being able to understand how different countries are implementing the policies that they have in place. Especially because the states in the US are diverse in some ways, but very similar in others. And I think it would be wonderful for us to be able to really capitalize on this opportunity to work with our global partners. So I won't belabor some of this, but here are some of the issues that we face in terms of just the product diversity, the targeting of different populations, the health promotion benefits and things like that really have a common issue in terms of managing the cannabis retail environment. And so also just understanding who's being targeted, how these retailers are appearing in communities, and what is the impact on different subpopulations. As we've already learned that a lot of this applies to tobacco, and I guarantee probably applies to cannabis. So again, and just to reinforce that there are so many wonderful things to be gleaned from global research. I know that those of us on the call probably appreciate this more than anybody, but I just really value the opportunities that we've had with this amazing team of researchers in Armenia and Georgia, as well as in Israel, And I think that we've really had a huge opportunity to advance the evidence base, to advance theory, to advance policy and practice, and to really build research capacity that has long-term sustainability based on what we've been able to do. So with that, I'll end and take any questions.
Great. Well, thank you, Dr. Berg, for a fascinating presentation and a great example of what we can gain from global collaborations. So we'll open it up now for questions, and I invite folks to turn your cameras on if you're comfortable doing so we can see each other during the discussion. As a reminder, you can type your question into the chat box or use the raise hand feature and wait to be called on, and we'll look out for those questions. And then when called upon, please just unmute yourself and ask your question. So I don't see any hands up yet, but I guess just to get things started, Dr. Berg, I guess I'm curious. You've given some examples here of how you've worked both in the U.S. setting and internationally. But at the same time, the work you've done around smoke-free coalitions and smoke-free homes in Armenia and Georgia seems very context-specific as well. So I guess I'm curious, from what you've been learning there, how much of what the findings there you think can be sort of translated to other settings, perhaps in the region or other low and middle income countries from that work?
So interestingly enough, there are those specific challenges just given the sociopolitical histories, the gender differences, and the astronomical smoking prevalence among men. We would assume that there would be more differences in terms of challenges and motives and things like that, but it's really pretty consistent across countries. Most of our findings are pretty similar in terms of like misconceptions about how to reduce the impacts of smoke-free secondhand smoke exposure. And the progress that has been made in Georgia in just the last 3 or 4 years, it's really interesting when we look at our data that because Georgia implemented their policies in 2018 and Armenia implemented theirs in 2022, we've just seen a huge difference that didn't exist in 2013. And so I think that speaks to kind of how quickly social norms shift. And I think, the US has had that social norm shift process, ongoing for years. So I think the challenges are unique for certain reasons, but I think the opportunities and the ways to address those challenges largely apply.
Great, thanks. And I see one question in the chat from Isaac Ergus. I don't know, Isaac, if you want to unmute and ask your question. Or otherwise, I can read it out. So anyway, so yeah, the question is, can you please talk a bit more about some of the obstacles you faced in getting your projects going, particularly in Armenia, and how you overcame them? I know you referred to many of the unexpected challenges you had around COVID and conflict and other things, but were there sort of conflicts to obstacles you faced in sort of on the ground getting those projects up and running, and how did you address that?
So that I can answer that in multiple phases, right? Like first, it's how do you identify strong collaborators? And I think we were very fortunate in just finding those people so quickly. And then there's the challenge of identifying or overcoming challenges, but identifying institutions that can operate under a US grant model, right? So we have different ways that we've had to structure grants because, the US model is we do the work, we get invoice, we get paid, and there's just like these floating expenses. And that is not the way that a lot of those countries can handle grant funding. And so we've had to work with them to identify ways that will work for them. And some of them are more painful than others. And I would say the other challenge that has come up is changing political contexts. historically in Georgia, their capacity is just unparalleled. They are fantastic. They have been leaders in global health or in public health in that region. And then with some political changes over the course of the last couple of years, things have really changed, and their ability to accept grant funding, their ability to execute grants in the ways that they had historically been able to, from things like incentives to, you know, things that they can say and not say, has really changed. So there's a lot of challenges, but I think some of those challenges also apply to working with other community-based organizations here domestically, where their models are a little bit different, or, you know, they might have different challenges in the ways that they have to execute things. So I don't know if I answered in the ways that you were expecting, but those were some of the challenges that I would mention.
Great, thanks. And I see Satish has a hand up. Go ahead.
Yeah, okay, I'm good. Thanks, Mark.
Okay, great.
Are we good? Yeah, so thanks so much, Carla, for a great talk. You talked a little bit about targeting of youth, particularly with some of the newer products that have come on the market. I'm wondering, have you seen adoption or initiation rates increase among young people? And then if so, some of the coalitions that I think you have managed to convene, I guess, are they aware of this and trying to get ahead of this? It does feel like there's a sort of opportunity window, particularly in relation to some of these novel products and young people, that we're at danger of missing out if we don't sort of get ahead of this relatively quickly. So I appreciate your thoughts on that. And thank you again for a great talk.
Oh, thank you. I appreciate it. And I appreciate the question, because we're kind of in this weird tension. So like in Israel, IQOS didn't really make that big of an impact, for better or worse. It's there, it's been there, but the uptake has not been huge. And in the States, you know, we clearly haven't had much of an experience quite yet, thank goodness. And then in Armenia and Georgia, like I mentioned, there is a more prominent, presence there of IQOS. We've talked about how to integrate that with what we're currently doing. But given the nature of this project, we have to kind of steer clear. But that is definitely something that we're working on. And through our 2 D43 research capacity building grants, we are doing some of the groundwork in terms of like assessing young people's attitudes and perceptions and use of these products. And so I think I have 3 or 4 students in Georgia and 2 in Armenia that are doing something related to these novel products and young people. So we're getting some really solid kind of observational data to hopefully support the next step, which would be to do something. And I love the idea of using coalitions, because our coalitions, they naturally gravitated towards working with the schools. So I think there is a cool opportunity there. So I'm glad you mentioned that.
Great. We probably have time for one more question, if there is one. Margarita?
Hi, Dr. Berg. Thank you for a great presentation. I wanted to follow up a little bit on the comment you made about the interest in sustaining and creating support to continue after funding goes away. And I'm curious, you mentioned some challenges before, and I'm curious how you're integrating that in supporting or developing those strategies that will help plan to sustain what you're currently working on after funding is done. Like, what is the role of coalitions, for instance, here? And I'm wondering if you can speak a little bit more about that. Thank you.
Okay, just to make sure that I am understanding the question, it was, how did we garner interest and enthusiasm for sustainability in these countries, and how would we
how are you I think I'm curious about how you're planning and what is important to support that interest in sustaining the efforts. So you mentioned there is interest, and I'm curious how you're thinking, or how the group is thinking about continuing that interest and actually developing a plan for sustaining the interventions in the long term.
So yeah, great questions, and questions that we grappled with. So with this new study, the coalitions are actively pursuing or identifying participants for the trial. But they couldn't stay focused on smoke-free air because that would have contaminated our intervention, right? So we worked with them to identify other ways that they might work in their communities and different things that they might target. And physical activity came up as one of them. And so their activities are going to focus around physical activity over the course of the next couple of years, while at the same time being able to reach and identify those people who would be potentially eligible and interested in the intervention study. So that was the first challenge. The other parts of it were, really that community coalition action theory, when people felt like they were valued, that they were able to expand their resources and make a contribution to their community. That really did lead to that sustainability and to that synergy that is so impactful for coalitions. So that's a huge finding. Like I said, Michelle Kegler is the expert on that. But just really in the qualitative interviews, it really came out as so important that they felt like their efforts were being honored and being impactful within their own communities. And these are smaller communities in the regions in Armenia and Georgia. So these are close-knit communities. So I think that's important. And I also think their connection to their national organizations and to our research team was really important. We became a community. And so when we get together, not everybody speaks English, so we have to figure out different ways. And so I, pull out my phone and then I show them my kid and I show them my husband, I show them my dogs, and pretty soon everybody's doing it. And it gives us a way to really relate to each other, even though there are those language barriers. And it kind of increases our commitment to our program, but also just public health and what we're producing. So I think there's some cool ways to just make people feel like their efforts are honored and important.
Great. Well, thank you. So I think that's a great note to end on. We're about out of time now, but I want to say a very special thank you to Dr. Berg again for joining us today, and to all of you who joined us. And that concludes our seminar series also for 2024. Recordings for this session and all global cancer research and control seminars can be found on our website, and stay tuned for more information about our seminar series for 2025. Before we close, though, I wanted to quickly mention that the call for scientific abstracts sessions and the Perline Award nominations is now open for the 13th Annual Symposium on Global Cancer Research. We invite you all to submit original research projects and programs relating to global cancer research and control, and encourage you also to nominate an outstanding professional in global oncology for the Perline Award. And the deadline for those submissions is January 17th, 2025. I'd also like to mention that registration is now open for the NCI Symposium on Translational Technology for Global Health, which will be held in Maryland on the NIH main campus, March 19th and 20th. And we hope you'll be able to join us there as well for what's going to be a great symposium. So again, visit our website, cancer.gov/global health, to find information about the seminar series, other upcoming events, funding opportunities, news, and more. And you can also follow us on X at NCI Global Health and on LinkedIn. So thank you again.
U.S. Department of Health and Human Services, National Institutes of Health, National Cancer Institute, cancer.gov, 1-800-4-CANCER.